everyone with an interest in NASH or more broadly fatty liver disease, Surf's Up. Season 4, episode 39 of the podcast, still known as Surfing the NASH Tsunami. Our look at the recent publication about the MASEF non-invasive test and its importance in our future starts now.
This week on Surfing the NASH Tsunami.
We need more sophisticated tests to identify patients at risk of dying from liver disease.
I'm not trying to claim this is the hemoglobin A1C of MASLD or MASH, but it's a step.
You can do an awful lot of things with this one result. You can use it in research, you can use it to diagnose, you can use it to, over time, assess effectiveness of different drugs in different patients. That's a pretty elegant platform to be operating from.
To put in a test like this could say how many at-risk patients were within those big cohorts, and did that differentiate in the outcomes of medications or placebo, for example. That's the sort of exciting thing that this could open as well.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guest, hepatology researcher and key opinion leader Mazen Noureddin, as they discuss Mazen's recent publication on the MASEF test and the future of NITs on Surfing the NASH Tsunami.
So first of all, I want to say I'm happy to be back from vacation. I assume Jörn is as well. I don't think you've heard either of our voices really for 3 weeks. Hey, Jörn, how are you?
I'm great. It's been a fabulous summer. A lot of positive memories and impressions, but it's also good to come back to work and see you and Mazen here online. So very happy for this evening.
And of course, Louise, and I'll note this very quickly, and then we will go immediately into icebreaker mode. We have all different day parts covered right now. It's 11:30 in the morning in Houston, where Mazen is. Good morning, Mazen. How are you today?
Good morning, sir. It's great to be here again.
It's 12:30 early afternoon where I am. It's 6:30 in the evening where Jörn is, and it's midnight in Perth where Louise is joining us today on our first full day in Australia. Hey, Louise, glad you're awake.
Good day, I am. Nice to have everybody back. I've been lonely the last couple of weeks, guys, while you've been on holiday.
And Jörn, we're not going to do a lot of this because I know that you're on a tight schedule today, but Louise and I are happy that we can both discuss football. Liverpool having a rather brilliant victory yesterday, and Tottenham haven't gotten off to the surprising excellent start of any team in the Premier League, so we're good. And Harry Kane now plays in Germany.
Just to add, I realized one of the English boys has switched sides to joined Bayern Munich. I think it's the English captain, and he scored twice already. That was big in the news. So
actually, he scored.
Give him a world-class team around him, he'll score now.
Oh, hush. He scored plenty for Tottenham. You know, it was his departure from Tottenham to Munich, Jörn, that led everybody to believe that Tottenham would be such a disaster this season. But with a new coach and a great attitude and a guy wearing the number 10 shirt who's not Harry Kane, but is pretty good in his own right, a guy named James Madison, we're off to a good start. With that, icebreakers. One good thing, personal, professional, in the last week, or in Jörn's case, in my case, the last 3 weeks. Brave one, go first.
I will. I have a lot, actually. It was a good summer overall. I did not travel at all in August, which is very rare. I'm heading to 6 trips in September and multiple international trips in October. So not traveling for a month is a big rest. My daughter is back to school. She's wearing her favorite outfit and she dreams about wearing that outfit. The other one at 2.5 is destroying the house. And I'm about to be done with renovation. So that took very long time and has been pain in the butt. So things are heading the right direction.
That's excellent. And I guess what you're saying is that the house was destroyed before the renovations and now it will be destroyed on a more or less perpetual basis by the girls.
Yeah, the 2.5 is she owns the world now and we're all following commands.
It's good. As long as you know who's in charge, it's an excellent thing.
Next, so I'll follow again many positive impressions over the summer holidays. One very personal is that the 6-year-old actually is able to swim now. For those listeners that are following that, I think I reported every once in a while hanging out in the swimming pool with her. Now she actually swims freely, which is exciting. You never think they'll get there, Mazen, but then at one point and they just take off. And if Stephen would be around, he'd say, they take off at different levels all the time. So looking forward to that. Of course, professionally, I share the excitement of Mazen not having traveled a lot, but it's a busy fall with a lot of interesting meetings and also a lot of data to be presented. So I think it's timely we get an update of a very, very recent paper published by you, Mazen. So I'm very excited to hear about that and then get more data in the fall coming out.
Recent and exciting paper. Totally agree. Louise, go ahead. What you got?
Well, I'm going to announce formally that I've been given the honour of being awarded a Fellowship of the Royal College of Physicians, which is the highest honour that physicians can give physicians in the UK.
Congratulations, Louise. That's fantastic.
Congratulations.
So not only am I definitely the first hepatology nurse to be given an FRCP, I may be one of only a few nurses ever to have been awarded an FRCP, and Florence Nightingale only was given an associate. So something I never thought that I would ever be in. The sort of thing to say is that Florence and I are now both within the Royal College of Physicians, but I do have to acknowledge that I could not have achieved it. And it's for the work within FibroScan over the last 15 years, taking it inside, outside the NHS, doing different pathways and patient thing. And I have to acknowledge here and now that if it hadn't have been for the support and assistance of my nursing, medical, allied health and patients going that extra mile to try and help people with liver disease live longer and find it earlier, that I wouldn't have been given this award. But it's a true honour because I was nominated by physicians, assessed by physicians, ratified by the Council of Physicians, and still awarded a full Fellowship of the Royal College of Physicians. So, yes, that's my certainly highlight, and it's probably a highlight for a very long time.
Louise, this doesn't happen to me very often. I'm speechless. That's amazing.
That is amazing. Congratulations, Louise. And it's not still. It's, I think, because you're evaluated by physicians, and it's a big achievement. Honorful, no doubt, and well-deserved.
Thank you.
And not surprising. Well-deserved, Louise.
Thank you very much. I was very surprised and I was speechless. And it was like, have they done due diligence here? They do know I'm a nurse. Yes, they do know I'm a nurse. And I will definitely be the first Australian registered nurse to be given a fellowship of the Royal College of Physicians.
You and Florence, huh?
Well, and Queen Rainier of Jordan, I think. She's associate as well. But I don't know any other nurses since 1515 who've ever been given a fellowship. But I shall do some investigation on that because it's like, really? Am I getting more than Florence got? Although we have to talk about different times here.
It's a different era, yeah. And if she'd not become an associate, I don't know that you could have gotten to this level. But still,
yeah, never a sentence that I would ever have thought I would be saying.
Louise, that's a remarkable and completely deserved accomplishment, and we're all thrilled for you.
And it's great to know that physicians respect nurses and hires that accolade for nursing as well, is that we can be recognised as a body and by our fellow physicians and medics, which is wonderful to know. Break that glass ceiling.
I've got nothing to report after that except that I'll go all the way from the heroic to the completely trivial. Had 2 great weeks at the Jersey Shore, and as I've noted, folks believed that Tottenham would be dreadful this year, and we haven't been. So we've gone from the heroic to the mundane, and now let's go back to the heroic, Mazen, and start talking about MASEF. We need you to do us a favor. We're realizing that papers like this aren't really seen by anybody who doesn't have subscription publication, not an inexpensive publication, and probably at least half our audience won't see this paper unless they deliberately go digging for it, because, as I say, hepatology is not a cheap subscription to get. So as you walk us through it, please keep in mind that we need to give enough detail so that folks who will not have an opportunity to read the paper unless you motivate them are so motivated to do so by what you have to say. I know you're really good at that, so I'm not worried about your rising to the standard. I just wanted to make sure you had it before we got started. And with that, my friend, the floor is yours.
Thanks a lot, Roger, for picking this paper to talk about. It's actually called MASEF, which stands for the Metabolomics-Advanced Steatohepatitis Fibrosis Core.
Okay, so the A is a short A, not a long A. Okay, I stand corrected. MASEF. Go ahead.
We're in an era of figuring out names and nomenclature, so we're straightening things out. We have MASEF, this is MASEF. So let me start with this. I think in the hepatology world of MASEF, we continue to look for the hemoglobin A1C. And I'm not trying to claim this is the hemoglobin A1C of MASEF or MASH, but it's a step. And there are other steps mentioned. I'll mention them. But to start with, this work actually goes back many, many years. It just makes me feel old and how long things take to get to a final product and how actually thoughtful research is. So I want to give the biggest credit to actually for this metabolic work, and especially in the field of MASLD, previously NAFLD, to Professor Jose Mateo in Spain, very well known in basic science and liver, and has contributed a lot to the field, especially in the glutathione and SAMe cycle, and more recently has done work in the metabolic field. Also his associate Rebecca Mayo and Cristina Alonso, they have done a lot of work. So this is how the story started. They were interested in metabolomics, and they have the techniques, including mass spectroscopy and NMR, which measure metabolomics in urine. And there were previous works published from this group, and we collaborated with them, myself and Arun Sanyan and many others on their work. So some of that work that came also that people may have not paid attention to is this test ability to distinguish between normal liver and MASLD or NAFLD overall, and that paper led to area under the curve of 0.8 plus something. And then to distinguish between NAFLD itself or MASLD and NASH or MASH, and that area under the curve was around 0.8. Then with the evolving field of MASH and risk stratification, when we found that MASH and F2 is the group that is of interest for clinical trials, and the reason why is because they have correlation with morbidity and mortality, we moved forward and created this score. This score is basically to identify MASH and F2 and higher. But what I'm trying to say is through this metabolomic spectrum that they have created, and as I mentioned, the test will become available in the US soon, maybe within this year or early next year, and CMS approved with its pricing. The report output will give you if the patient has MASLD or not, NASH or not, and NASH, MASLD and F2 or not. And you'll see it on a kind of colorful traffic light kind of spectrum. So going to the MASEF score. So this is an international effort, actually. It's one of the most diverse cohorts. And we have multiple co-authors who are lead authors in the field, including, I'll give you examples, and I'm sorry if I'm going to forget anyone. Marco Arisi from South America, Ken Cusi. We have Manuel Romero Gomez from Spain, Professor Javier Crespo from Spain. From the US, we have Arun Sanyal, myself, Stephen Harrison. We have Tatiana Kushner as well. From the UK, we have Quentin Ensti, and many others. And everyone contributed to this sample. So the sample was, the testing cohort was almost 800 people, or 790, and the validation was 560 plus something. And the test compared the MASEF, which is again serum-based test that tests MASH and F2 and higher versus not, to the FAST score. We also completed with FIB4 and NAFLD fibrosis score and many others, and transient elastography by itself, and it turned to be better, or at least equivalent, so to be more accurate. So MASEF consisted of 12 lipids, BMI, ALT, and AST, and did very well in the testing cohort of area under the curve in the high 0.7s, as well as in the validation cohort.
Mazen, you mentioned the cohorts are unique and very diverse. Before you come to the accuracy and some of the test characteristics, I realize you used a large derivation and validation cohort, and that's also derived from all these different centers, which are all referral centers. Is that correct? Or you have some more, I believe Stephen has some networks where there's more of a broader access to patient samples, maybe? Can you give a little bit more insight and background?
Well, actually, we did not use Stephen's cohort. The US cohorts were from my previous place at Cedars-Sinai, as well as VCU and Mount Sinai. The cohorts were mostly tertiary care centers, but many places in Spain and Chile and Mexico were also tertiary care center, but they were more liberal in performing liver biopsy.
I agree. They're known for that. I agree. They have a broader and a different spectrum. So one of the strengths looking from the outside is that you have from the two continents patients, no Asians, if I'm taken correctly. But still, I think a pretty broad spectrum of liver disease here. And referring systems.
Yeah, and another important point that in the, I guess, the testing cohort or development cohort, whatever you want to call it, we did not include F4 intentionally because, as you know, if you're looking for F2 and higher, if you include F4s, the area under the curve will improve because you have like a wider range and the AUC will perform better. So in the testing cohort, the area under the curve came as 0.76. And in the testing cohort, in the validation evaluation cohort, the MASEF performed as 0.79, and importantly, there was head-to-head comparison with the FAST score that performed as 0.74. It was not statistically significant, but numerically, many things of the MASEF score compared to the FAST were numerically better, like such as sensitivity was 0.79 versus the FAST was 0.59. I think the most important aspect of this paper is table 5. Currently, as you know, with the AGA, ASLD, and EASL algorithm, you do FIB4 and then they direct you toward ELF or transient elastography. Well, the problem with ELF, it doesn't tell you NASH at all. It doesn't tell you NASH and F2 and higher. It's prognostic tests for those that they're going to progress to cirrhosis and those they're going to progress to decompensation. But MASEF is NASH and F2 and higher. So this is what the test did. Again, what we did is we went to the AGA and ASLD and EASL and we said, okay, let's do the same. Instead of FIB4 followed by transient elastography or even FAST, we did these various comparisons. Let's compare FIB4, transient elastography, including the FAST, with FIB4 followed by MASEF. And the good news is, again, I will point people to table 5, that the algorithm starting with FIB4 followed by MASEF did similar by p-value to the FIB4 followed by transient elastography. Indeed, if you look at the numbers, there were many other numbers that numerically was better for MASEF. But what that means is the following. Let me give you first numbers. If you look at the FIB4 followed by transient elastography compared to FIB4 followed by MASEF, the FIB4 MASEF accuracy was 71 or 72% compared to 69% FIB4 by transient elastography. Sensitivity was higher, 61% for the MASEF pathway compared to FibroScan pathway of 54%. Specificity was similar, so as PPV and PPV, both MPV and PPV. And the indeterminate zone were 16 and 20%, not statistically significant. So here you have the first time, I think I see it in NIT's paper, that you're testing the new algorithm using FIB4 followed by imaging that requires referral and patient fasting compared to a test that can be another blood test, which is still sent out, but it's probably more convenient, and they performed similarly. So one of the suggestions we have, maybe this needs to be looked at in the future as current of pathways for more convenience.
Mazen, can I just ask, because obviously the setting for MASEF is going to be clinical research, predominantly some of the gastro centres. Now, most of those are going to have FibroScan. Did you look at adding MASEF to liver stiffness to see if it was even more accurate, like you've done with the FIB4?
That is actually a great point. We have not done that. The reason why I actually will comment on your first point, trying to do is not clinical research only. We're trying to replace or trying to find something convenient for GI Hep as well as the primary care for the second test after the FIB4. So as you know, a lot of people, they don't have a FibroScan and they say, what do we do? So here, the FIB4, they can do the FIB4 and then they can send that test out, which can perform equivalently to the FibroScan. And it will not just be clinical research, because as I mentioned, it will be commercially available per the company in the US later this year or early next year. And I can tell you what else we're heading to in the future with this test, which is important to see how well it is in other contexts of use. But that's the concept of the MASEF test.
Adding it to FibroScan may well even make it more predictive, but also one of the strengths of FibroScan is the fact that you do not need abnormal liver function tests to detect a liver at risk, whereas a lot of the metabolomics do require elevated AST, ALT, for example.
Which this test did not require. We had normal liver enzymes and that.
But no, it's exciting.
Yeah, the point you're making is clearly it'll be more applicable if you have a one-time test versus sequential testing, moving patients back and forth, sending them to specialists. On the other hand, the two-tier system testing allows to test in primary care and then refer to secondary care. We know there are weaknesses. So I think there are pros and cons to these approaches. Questions about costs then, and you know this well, and you've done some cost analyses in this area. And the second question I would have is, of course, to the metabolomics. How difficult will it be for non-experts to sample and run these tests? You mentioned it might be available at the large scale, so it sounds feasible.
Yeah, that's a great question. So So when people hear like there are 12 lipids and in addition to liver enzymes and BMI, they're like, oh God, another formula and calculator and I have to plug it in. The answer is no. It's going to be one sheet with the spectrum of mazzled, no mazzled, NASH, versus mazzled, and NASH and F2 versus non. And it will come in one report as you mentioned. So it will give you the score and an interpretation of the score. We also have like similar to the FIB4 and NAFL fibrosis, to FIB4 and the transient elastography by the guidelines, there is a gray zone. And the gray zone was similar to the FAST as well as the transient elastography statistically. Nevertheless, if you do the FIB4 followed by MASEF, similar to FIB4 followed by transient elastography, which is a concept now is well known in hepatology, if you do sequential, you narrow this indeterminate zone, and that's what MASEF did, similar to what the FibroScan that preceded by the FIB4 did. So the indeterminate zone is quite low. And as Louise mentioned, in primary care and GI and Hep offices, you can always add a FibroScan and see what it is. So some of the work actually we are looking into the future is one, to start with MASEF immediately rather than FIB4. We stick in this paper to the FIB4 first, followed by MASEF, because it's in the guidelines now, it's acceptable, it's applicable, and it's cheap. Of course, MASEF will be a bit higher because it requires special testing. So we'll look into that and its cost effectiveness as well. Another thing we're going to look at, now we started having effective drugs, we're looking into partnership with companies that they showed efficacy with their drug. And there's so many of those like Madrigal, Novo Nordisk, Akero, 89 Bio, and many others. So we want to see if the MASEF moves the same direction with the histology, which you imagine that it should, if it's like reflecting the spectrum so precisely. Finally, we will also look into what the FDA and EMA are looking for, which is the prognostic predictability of MASEF in correlation with outcomes. And we need cohorts to test that, such as the NASH CRN, and if there are such samples.
Can I ask, with the FIB4, obviously we're looking at an age cutoff of around about 35. Was there any age difference? Because both of the cohorts, I think the average age was 51 and 54. So is there any strength or weaknesses that you've noticed in different ages and sexes?
No, actually, we did the analysis in the MASEF in particular we did sub-analysis, not all of them published. No difference in age, no difference in diabetes status, no difference in BMI and other parameters. What the reviewers asked us smartly is to look at MASEF in shorter form, meaning you have lipids, you have liver enzymes, and you have BMI. So they asked us to take BMI, take out the liver enzymes, and see if lipid alone will do the job, or, different parameters. And what we found at the end, that adding all these parameters to each other, again, the doctor does not need to bother with them, rather he will get the report. But adding all these parameters to each other was important to improve the accuracy of this test, which makes sense, right? You have liver enzymes, you have a very important factor in the metabolic syndrome, which is BMI, and you have the lipids, which reflects the underlying pathophysiology in the liver and probably somewhere else of the disease, all combined in a holistic type of test.
Sounds great. Could you, therefore, use it retrospectively to assess some of these big cardiac studies? Or do you need... they don't probably do the lipid profiles. I was thinking about trying to assess how many were at risk, muzzled and MASH, in those studies, but without the lipid component at that level, I suppose you wouldn't be able to get that, would you?
I mean, we need cohort, try to test things. It's a good amount of blood to make sure we're testing, validating, and do it very precisely. So we are on the search for, as I mentioned to you, search for a cohort that will look into outcomes, and NIT that we talked about could be one of them in the future. We are searching the cohort for testing response to therapies.
That's what excites me, is at the moment we're missing all of the patients on these big cardiac studies, the diabetes, the weight loss, that we're not assessing because we're not using other than basic liver function tests, and we're certainly not fibroscanning those patients. Whereas to put in a test like this could say how many at-risk patients were within those big cohorts, and did that differentiate in the outcomes of medications or placebo, for example. That's the sort of exciting thing that this could open as well.
And you're right. And when I say we're looking for outcomes, definitely MACE will be one of the things that we look at in such cohort. What I can share is that we already have, although the paper is very green and just came out, we had an interest from pharma to test these cohorts in terms of their treatment response. So we're still at early stages, so hopefully, contracting all that will not be an issue, and I will see the science results soon. So it's exciting that way.
It's pretty elegant, Mazen. I mean, one of the things that strikes me is that you can do an awful lot of things with this one result. You can use it in research, you can use it to diagnose, you can use it to, over time, if I understand you correctly, assess effectiveness of different drugs in different patients. That's a pretty elegant platform to be operating from, if I understand correctly. Am I getting that right?
Yeah, and also for inclusivity of the field, the other test we have like this is the NIS2, right? That just came out in JHEP. I don't mean to say this test is better than the other or the other way around. I think both should be tested in future cohort. NIS2 was tested by Nimble. Nimble also had the metabolomics by this company that produced this test, but they did not have the MASEF test yet. So Nimble needs to test that. I mean, one of the things about the NIS2 is that it came only from the GenFit cohort and it was not tested in other cohorts. Here, arguably, we have like international multi-center, as Jörn mentioned, like widespread population that have been tested on it. And in the future, these tests need to be compared to each other and see how they do in terms of the diagnostic, how they predict response, and finally, how they correlate with the outcome.
If you compare this to NIS2, is there reason to believe over time that one will be more cost-effective or easier to distribute widely? Or do we just not know the answer to that yet? How would you approach an issue like that?
I mean, they will probably both be one of the major laboratories, and we have like few on these countries. I don't have an idea about the cost of this versus that and which one will be more expensive, but you really want to think about multi-step, and that's why we did the comparison FIB4 with MASEF. So we wanted to stick to the guidelines and start with the cheap test that now everyone is agreeing on. Although I have also like some research now we started looking at the data, and FIB4 has its downsides, and I'm not gonna go to that today. We went to it in other episodes, but starting with FIB4 followed by a blood test could be on the long term more convenient and cheaper than having machines and referring to the patient and fasting and go to another facility and all these things. So again, it's not a competition. We're just trying to reach precision rather than which one is better, and patient convenience.
Along the line of comparing it to other blood-based markers, Mazen, it's very intriguing to just add on a number of metabolites or lipids and inflammatory cytokines. From your feeling, I mean, maybe you've played around a little bit and you took out some or you added some of the groups in Spain. Will we, by expanding the number of analytes, will we increase sensitivity and specificity? Will we increase the noise? What's your feeling here? I mean, FIB4 clearly underperforms because it doesn't have a lot of link to the pathophysiology. It's a fibrosis test and not a good one. The more metabolites you add, the closer you might get to certain subphenotypes and stuff. I'm not sure you have an answer, but your gut feeling.
I do. So again, the credit will go to Rebecca Mayo, Christina Alonso, and Yvonne Martinez-Arnaz, that they did a lot of these analysis. So the goal is really, right, to find the least possible, so the cost is down, but yet you maintain accuracy, as you said. And they have done a lot of phenotyping. We have another paper in gastro and animal and humans phenotyping by metabolomics, and they were much higher. So one of the exercises or the stress tests with this test that Rebecca as well as Yvonne, went down to the least possible test that we need and still maintain the accuracy. And they came up with these 12 different lipids. So that's a great question now, Jörn. And it's very important for the cost as well, timing. So they did it that way.
All right, thanks.
Pediatric cohorts, are you going to be rolling this out to pediatrics and adolescents? Because, of course, this is our rising concern at the rate of childhood obesity and the early onset diabetes in these populations. Are you looking to roll this out? Because that could be a massive alteration.
Correct. Massive will be massive there. So then let me make the call on this podcast. And I'm guilty that as an adult hepatologist, I don't have an access, or sometimes I don't think about the younger population, which is a mistake on my side. So if anyone wants to test this MASEF test and the adolescents or pediatric, I think that will be huge, and we're happy to look at it.
I love the idea that the test is called MASEF, because some of the things you're talking about actually are quite massive. Just talking about homonyms and only in English, but that works. So what next that you haven't mentioned yet? What further evaluation do you think you need to do, or do you plan to do next year to figure out how broadly and applicable this will be, and what kind of time frame, to the degree you can estimate a time frame on this stuff?
Yeah, I think, again, when I write papers, if you write with me, it's quite painful because I double check a lot of things a million times. And I'm very cautious. So I would love to see the validation in this and other cohorts, although, as I said, this is like multi-center international cohort. So I would love big consortia to come and confirm these findings from multiple international experts. And I say that in general, I feel like in the field of NITs, if I come up with a score, like I'll give you an example from my personal experience, the MAS score with MRIs, I really enjoy when I see other people trying to, or I'm really happy when other people try to validate these scores. Laurent Costera presented data from his cohort on FAST versus other tests. So these kind of works need to be done in this next step. I'm surprised, although like the process of this has been ongoing for years, I'll say more than a decade of these metabolomic work and different cohort that they led to multiple tests of this. But I'm surprised how fast the company is taking it to the market, especially in the US. Of note, the metabolomics test that the Spanish company has is actually part of the algorithm in the Spanish guidelines. And now it's commercially available there, and they're gonna translate that into here. So I would love to see how it performs in GI and Hep hands. Why we keep confirming with other cohorts and look at the treatment response as well as outcomes. I think this is the big picture of the test, but I'm happy to take any suggestions, collaborations from others, and keep going with the test as far as we can go. If it proves to be a good test, let it be. Hopefully we'll replace liver biopsy and not needing too many things to help our patients. And if it doesn't, hopefully another test will do so. But so far it looks great to us.
How would you adapt it for MET-ALD? If you were to look at that, what would you suspect you would have to add? Because now we've obviously had the nomenclature and we have changed. And in fact, I've used it recently in discussing with patients with alcohol, is that I now have a category I can talk to them that could be from the nomenclature, which we didn't have before, which was quite nice. And they responded to that really well. So if you were to think about how you would adapt it in the different areas, what would you think you would need to add?
That's a great question, Louise. Indeed, like we are about to submit a paper tonight or a research letter on MET-ALD versus MASLD. And our first observation from the enhanced cohort that the prevalence of MET-ALD, that specific group, is not that high as you would think. Meaning like people that they drink on the borderline are not as prevalent. Either they don't drink and they're MASLD, or they drink more than the amount and they classify it as ALD. What also came to our surprise in that paper that you would think that MET-ALD will have more stiffness on FibroScan and more fibrosis eventually, right? But what we found from the enhanced data that this MET-ALD group, they had a similar prevalence of advanced fibrosis and cirrhosis compared to MASLD. So here you're like, oh, is that plausible? It could be. Why it's plausible is because one, it could be that the amount that we said, well, you cannot drink to that amount, it was made 20, 30 years ago. Maybe that extra amount is still okay. On the other hand, also you can argue that there are data showing that moderate alcohol consumption, especially red wine, is probably not too harmful or protective. So we need way more there, and including testing such a test in such a cohort. I don't know how it will perform. The nice thing that metabolomic could be similar between some alcohol and MASLD. So we need to test in that group and see how it looks like. But you bring in a very important point, which is the following. What we say in this paper, maybe we disadvantage that group of clinical trials of MASLD for no reason. Maybe they should be included or should be tested for MASLD related drugs. Change is difficult, and some people are looking into the nomenclature as difficult change, which I understand. But at the same time, I can see how it could solve. As I mentioned before, I voted to keep it as NAVL, but yet I'm excited after I accepted the voting process that MASLD then hopefully will let many people to maybe come together, explain it to the patients better, and open this. My most excitement is actually this group, MET-ALD, that open another group of patients that they can benefit from multiple things and another area of research.
It also doesn't stigmatize so much, I suppose, in that, because you've got alcohol and it's allowable as part of that process, and therefore it's something that people respond to change slightly, and they can see that they can make a change. That's this ability now to say, well, there's now a classification for it. It doesn't necessarily mean it's one or the other. It could be assessed. You need more cardiac assessment. You need various bits and pieces to be more thorough. I've certainly seen people respond to that so far.
Yeah, we're leaving the discussion of the MASEF a little bit, but I like it because I agree with you that there's a lot of excitement about the new categories. Lipidomics should react a little bit different to alcohol, is my understanding, so might be a different pattern. The second thing, if we now dive into the MET-ALD categories, I think we have to consider that in the past we're trained to think in two boxes, right? NAFLD, ALD. So now we're trying to break this down into a little bit of in between, which in retrospect is probably challenging. I think we need strong cohorts setting them up prospectively and define the amounts according to the accepted cutoffs.
I agree. And the challenges with the prospective cohort, if they will change their behavioral once you enroll them. But the bottom line is there a gray zone? I think there is a gray zone. We all know. I mean, Roger is probably...
Hey, I live in the gray zone, except that I'm not obese enough.
Just kidding, Roger.
He's been on all
and
of it.
my liver is clean. So in fact, I am MET, but not SLD. It's all right. I drink a little, I eat a little, but my liver's clean, so it's good. I get it tested every time I go to a meeting.
I'm just trying to wake you up.
I'm awake. I just figured these guys are a much better place to do this than I am. So, in all seriousness,
you must have brought that joke in a different meeting, Mazen. I think you're prepared for that one. Anyways,
Jörn, that's how you know your friends are. They're the ones who pick on you first. It's a good thing. I kind of like it. But no, I mean,
I've attacked everyone on this program, so I have to be careful in the future.
Yeah, although, Mazen, the truth is, Matt Damon aside, the comment we've made about nomenclature since the beginning is that one of the things we all liked about it was the idea of MET-ALD and the idea that you were taking there's this high artificial wall, and we're not going to tear the wall down and figure out what it looks like. So that's, I think, really exciting. To Jörn's point about the lipidomics and yours, it also makes it more complicated, right?
So you guys just gave us like 5-6 projects to work on, which is exciting. This is like really what you wake up for and try to contribute to and work with others and solve patients' problems.
Can I ask, were you able to break down any socioeconomic differences in those at risk within that population?
We have not, within the MASEF paper, we have not. It's the group is really homogeneous, that it's like there's Chile, there's Mexico, there's Virginia, there's Beverly Hills, Cedars-Sinai, where I was. So, and it's like bits and pieces. I'm not sure we'll tease out that, but yeah, it big cohorts like UK Biobank, although I think it's shifted towards certain population. But to Jörn's point, either for MASEF or MET-ALD, we need a larger prospective cohort with multi-ethnic groups. I think the NAIL-NIT will provide that eventually because it's multi-center prospective study with multiple U.S. and international sites.
Interesting. So, Mazen, we've covered this whole topic in 46 minutes, which is really efficient. So we now have, I think, about, if to the degree we have time, and Jörn, you've been really generous, given I know you've got other commitments right now. If there's anything anyone would like to speculate on or ask questions, let's get a little further out into fantasy land here and see where we go. And Louise, I think you've been pretty good about this so far in terms of we've got MET-ALD, we've gotten to socioeconomics, we've gotten to different populations. Mazen, are there any populations we've not mentioned that you think might benefit from more work on this as you go forward?
No, I mean, it's like you really need to keep testing it and find out if I think the next step for us is response to therapy and correlation with outcomes. There are multiple contexts of use that the FDA came up with, and we're looking for more discussion with the FDA and clarities in next month or next few months. There are exciting things coming from the FDA, and thanks to them for pushing also the envelope that way. In my simple mind, I always broke it down into 3 things, not the multiple context of use. I say, like, when a patient comes to use, like I say, is how bad am I going to live? And am I getting better? Which is diagnostic, follow-up longitudinally, which is a response to therapy, and prognostic. And I think we need to move any NITs at least to these 3 areas. And if one NIT can cover them all, let it be. That's perfect. That's A1C. If not, we can combine as far as we move away from the liver biopsy.
Yeah, the only other area that maybe comes back to my mind is, of course, the cirrhotic population. Mazen, you mentioned you did on purpose not include them to not oversell the test metrics, which I think is a good thing because you approach this critically. Of course, identifying patients with compensated cirrhosis is one of the challenges and something people will want to use a test for.
So I'm glad you brought this point. Let me clarify. In the testing cohort, we did not include cirrhotic because it will shift the AUC into a better AUC. As you know, in the validation cohort, they were cirrhotics. And here we go, another project. We can probably ask the metabolomics folks to look into cirrhotics in particular and have like a test for that. So that report that we have can give you MASL, no MASL, MASH, no MASH, MASH F2 and not, and cirrhotic or not. So that's a great suggestion. Actually, we can go there and get it done. It's just like you need a good number of patients, and we just need one of the pharma companies maybe to give us their cirrhotic cohorts and test it there.
So at that point, I'm going to declare that we've covered the landscape, right? I mean, we've now gotten to demographics, we've gotten to disease severity, nature of disease, different tests to compare. With that, let me just ask a closing question, which is, let's pretend that we're 2 years out from today. Starting with Mazen, because you've been living closest to it, and the rest of us are just going to kind of make it up. What do you envision the practical use of MASEF will be 2 years from today, if you had a guess?
I mean, it will be in use for diagnostic in the next few months, and we'll see real-world cohort data. If it proves to show a correlation with histology, I can see one of the approved drugs using it along with their approval to replace liver biopsy, because as you know, that MRIs are quite difficult to get. So I'm hoping that at least we can get to that. Whether it will be in phase 3 clinical trials as one of the endpoints or not, I cannot claim that. It's a stretch. I need more data such as outcomes.
That's excellent. Jörn, if you had your wish list, where would this be in 2 years based on what we've heard about it and what we know?
I think I'd like to see those more sophisticated tests being moved into a broader group of physicians using them, having access, having reimbursement, patients opting to buy that test for themselves to maybe spare them inaccurate or let's say non-conclusive testing results and having liver biopsies done. So I do want to say I think this is a great paper, Mazen, and although it might have taken some time, it's always great to see those collaborations come to the end, and I think it's inspiring for the field because I want to see more than 2 transaminases and platelets with age to define an at-risk population of liver disease in the future. So I think that's kind of down the line what you said, but from a different perspective, we need more sophisticated tests to identify patients at risk of dying from liver disease.
Louise?
I echo what Jörn's just been saying there, because I think if we can walk people into a primary care practice and pick out the world's largest cohort of adults affected with poor liver health and the more serious end of that, whilst there may be a risk that we will miss the minor ones who don't have, it's still better. That's exciting. And I think now we've given him an awful lot of projects to work on. Obviously, the pediatric, the adolescent populations would be extremely, because we can go from both ends. I know the average age of these populations are 51 and 54, but if we start and tweak it to find the highest risk people now in these areas, but we still have primary care to start to think liver, because they're not going to request the test unless they start to think that they can see. And obviously there's lean NASH or lean MASH and muscles. But no, it's dead exciting and we're getting there, and great work to you and the team. And I just would love to have sat around the nomenclature you did for the name and keeping it simple.
That was actually way before MASL came out. So I think the name we came up with a year and a half ago or 2 years ago. And when MASL came out, I was like, oh, they go along the same math club.
Well, yeah, and obviously for English speakers, the name is MASEF. So Louise and I were talking about this before the call. I have two thoughts. First of all, Mazen, when you talk about A1C, I think to me, as a marketing researcher, one of the benefits of A1C is it made primary care a lot more confident looking at diabetes because they had one number they could watch, right? So if we're going to make liver disease something that primary care treats, the ability to get closer to that A1C kind of structure becomes huge. I'm not going to keep using the word MASEF. It's been used entirely too much in this conversation in too many ways, but huge. Number one. And number two is there's a vast population for liver biopsy just isn't realistic, period. Not only is it a bad idea, not only does it have the problems we all know about, but the economics of the location of patients just make it impossible. So the ability to deliver tests test not relying on biopsy that gets to the level of granularity that you're talking about here, which is kind of the flip side of the A1C thing, is huge because it enables people in more remote environments and in less economically privileged nations and economies to be able to treat more patients and evaluate more accurately. So it seems to be exciting and important from so many perspectives, which is why as soon as you drop me a note saying, would you like to cover this, we took the first week that we had everybody here and did this, and at an odd hour for everybody because it was worth it. With that said, I will be back with Business Report in a couple of minutes. We will see you all next week for our next episode. And Mazen, thanks again for joining us today.
Always a pleasure.
Okay, let's all say goodbye for now. Bye-bye.
Bye.
Goodbye.
And now for the Season 4, Episode 39 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. A lot of news in just the last 36 hours on this subject. Russia confirmed that former Wagner chief Prigozhin was killed when his plane exploded from what appears to be a bomb midair. It feels to me like kind of a new version of what they used to call window cancer, in which opponents of Putin were killed falling out of windows from high-story buildings. An article recently indicated that as much as 1/3 of Ukraine is heavily mined by the Russians, which would be the entire land area the size of the Baltics, and it feels like an unspeakable horror for the people who have to live and wade through that. With all this going on, however, CNN reported today that Ukrainians are still summering at beaches of Odessa, but that the beach is no longer the carefree experience it was before the war. Finally, the counterinsurgency appears to be gaining ground, although it's unclear exactly what its long-term prospects will be. We're rooting for them. Slava Ukraini.
Louise Campbell, FRCP, has a nice ring to it.
Louise Campbell's announcement during today's podcast that she has been chosen to become a fellow of the Royal College of Physicians is a remarkable and well-earned accomplishment. I join my podcast colleagues and the entire fatty liver community in congratulating her on receiving an honor as well-earned as it is rare. After all, I think she said this on the podcast, but there are only 15 nurses in the FRCP today, more or less 15.
September is for conferences.
As we head into September, please remember that Paris NASH is September 7 and 8, and the SLD Summit, what used to be called the NAFLD Summit, is September 21 through 23. I'm hoping to be at least one of those in person. We'll discuss our coverage plans next week.
As predicted, download levels were down for the second half of August.
Given that we ran 2 weeks of older episodes and did not post our E38 conversations until Monday, it is little surprise that total downloads for the month are lower than in our record months of June and July. That said, we did cross the 190,000 total download barrier over the weekend and appear likely to go well over 8,000 for the month, despite the replays and the delayed conversation.
This week's Vault episode looks back to earlier NIT discussions from NASH 2023.
This week's Vault episode is episode 3.2 from season 4 and consists of today's participants plus Stephen Harrison discussing some of the NIT presentations and insights from NASH 2023. It's worthwhile keeping some of these points in mind while mulling over the importance of MASEF, NIS2, and the other upcoming NIT advances. So that's it for this week. Again, I want to extend profound congratulations and express my deep pride in our colleague Louise for her recognition from FRCP, and to thank her, Mazen, and Jörn for joining us at their disparate time zones today. Also, thanks to Mike and Jake for everything they've done to get episodes out over the past 3 weeks. We record our next episode the day after Labor Day and we'll post on Wednesday. Listen for a discussion of September's conferences and an announcement about the future of this podcast. Until then, stay safe, surf on, and we'll see you next week.
Have any questions for the surfers? You can send them to surfingnash.com and we will answer on the podcast or the website.